Every year, we choose a chair or former chair of the Department of Psychiatry to honor by giving them the Chair Award for lifetime contributions to the field of psychiatry. There are some past winners here in the audience, Dr. Zaromsky at WashU, for example. This is a decision that isn't taken lightly because we have a number of luminaries in the field of psychiatry that have served the field for many years and made seminal contributions. And so this year, it's my pleasure to be able to present the Lifetime Achievement Award to Mark Gold. And I want to tell you a little bit about Dr. Gold. So first, I should say that Mark and I have known each other for a very long time. And we've known each other for 30 plus years. For more than 40 years. And to tell you a little bit about Mark, he was trained at WashU, at Yale, and I first met Mark when he was running this really wonderful hospital in New Jersey. And he published a paper on the role of symptomless autoimmune thyroiditis in mood disorders, in particular in depression. And I was working at the time in Chapel Hill on my PhD dissertation was on the thyroid axis. And I read this paper in which Dr. Gold had first quickly understood the different grades of hypothyroidism, and there are 4 of them, and that he had gone on to show that patients with mood disorders had remarkably high rates of autoimmune thyroiditis. This was one of the first demonstrations not only of the link between thyroid disease and mood disorders, it was one of the first demonstrations of an entire field, namely psychoimmunology, the notion that autoimmune disease occurs at far higher rates in patients with mood disorders. And as you know, this entire field of psychoimmunology has opened up to now we know that there are patients that have a subtype of depression with a tremendous amount of inflammation. So he was measuring a variety of other things in these patients. Some have turned out not to be fruitful, like measuring urinary catecholamine excretion, MHPG, and the like. But he was a pioneer in that area. And then he turned his interest to doing 2 things. One was writing popular books for the lay public about depression and then subsequently about mood disorders, something our field was not very good at the time. And so Mark turned his attention to addictive disorders, and he relocated to the University of Florida, was one of the founders of the McKnight Brain Institute there, and worked very closely with neurologists and psychiatrists, and then realized that there was a need for treatment of patients with drug abuse. At that time, there were no patient advocacy groups for patients with drug and alcohol disorders. And he actually, in an ingenious move, convinced his institution to buy a former Marriott hotel and convert it into a treatment center for patients with addictive disorders. So he has been honored in a variety of ways. It's extremely well published in the area of addictive disorders. He's also now spread his wings a bit and is looking at eating disorders as a form of addictive disorders. So it's my privilege to present him with the 12th Annual Chair Achievement Award.
Thank you. Appreciate you very much. Thank you. Me too. Thank you.
It's all yours.
It's all mine. Thank you. It's a real pleasure. So here we go. Learning objectives. We're going to talk about opioid use disorder. It's a major national catastrophe. It caught everyone by surprise. it shouldn't have, and what we do about it. We'll look at the clinical evidence, the various treatments, and what the long-term outcomes are. We'll talk about approaches to treatment and how everybody needs to work together to optimize treatment outcomes. For anybody that's been to my case reports or other workshops, there won't be a lot of overlap, but if you have a question, I'll have time for that too. It could be from any of the forums. It's estimated that 2.1 million Americans have an opioid use disorder. Opioid use disorder is chronic, lifelong relapsing without a cure. And by the way, all of the references were updated by Jan and I recently. There's 2020 references from last week. And just if you cut and paste them out and Google them, you can get the PDFs usually. They're open access. But opioid use disorder, in the current way of thinking of it, usually requires intravenous administration. And that plus the typical lifestyle means that you have a lot of infectious disease. There's been increases in hepatitis A, B, C, and HIV, all attributed to it. And about, at least 2/3 of the opioid use disorder patients have had an overdose, many of them more than one. However, doctors don't like these patients. Now, why don't they like them? We talked about this in one of the breakouts. One reason is they're not grateful. If you ever, we'll talk about that. If you think about other rescues, Heimlich maneuver. How many people have given a Heimlich maneuver and saved a person's life? Did they thank you? Yes. How many people have given CPR and saved a person's life? Did they thank you? Yes. How many people have given naloxone? You're laughing because you know the answer. How many people have given naloxone to somebody that's overdosed and dying? Did they thank you? No. Did they hit you? They yell at you. They could hit you and yell at you. It's so amazing. You save their life. They wake up and they say, "Why did you blow my high? I was just dreaming. I was floating along, and then you came and interrupted it." And you go, "Well, you had a pulse of 20, maybe. You weren't breathing. Your lips were blue. It didn't look good for you." And they'll say things to you that you can't really believe, and I shouldn't say out loud. So most emergency room doctors, 1 out of 10 found caring for an opioid use disorder patient satisfying. That's pretty difficult to get good care if 90% of the providers don't want you there and don't feel good about it. And for family medicine, they would say these patients are not treatable. Psychiatrists would say they don't fit in their office. Many people say that giving methadone or an agonist-based treatment is simply substituting one addiction for another. And less people in women's health and other disciplines just don't feel that this is for them. So, how does it really happen? You could have risk factors, and I don't think I have that in this talk, but things like sexual, physical, emotional trauma. Those are risk factors for use. Being exposed in utero, risk factor for use. Early initiation, risk factor for opioid use disorder. There are a lot of different risk factors, but where the rubber meets the road is you have to try the drug. Now, once you try the drug, the question is, will you do it again? Well, if you just put yourself in my shoes and say, what's the animal model for showing among all the substances in the world that a substance is a substance of abuse? It's animal self-administration. That's it. That defines it. It isn't withdrawal anymore. It's use, stimulates its use, And use begets use, begets use, begets use. And it's so simple to show in an animal experiment. You take an animal, you put him in a box, you give him a telegraph key, you hook it up to an IV, you put in an IV bottle up here, and you put in cocaine or morphine or THC, but let's stick to opioids. You put in opioids, and the animal, out of curiosity, eventually hits the lever. Looks around and goes like, you mean that's all I have to do to preserve the species of rat? That's it? I can get a direct line to the reinforcement center that says, good, do that again, 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 again. And so if you take 100 rats, divide them into two groups, 50, they're all related, 50 get unlimited access to cocaine in a self-administration model, 50 get unlimited administration of morphine. What do you find at a month? Well, the cocaine animals hit the lever, hit the lever, hit the lever, hit the lever, and they basically hit until they have an epileptic seizure or cardiovascular event and die. And you come back in the experiment, they're dead. The opioid animals hit the lever, hit the lever, hit the lever, not off. Hit the lever, hit the lever, hit the, not off. They find a maintenance program for themselves. So even in self-administration models, the cocaine animals are activated by use and die quickly, and the opioid animals can find a maintenance. And in the history, if anybody's here from Johns Hopkins Hospital, in the history of Johns Hopkins Hospital, the founders of Johns Hopkins Hospital included one cocaine addict and one morphine addict. And the cocaine addict eventually went up to Yale, but he would periodically have to be hospitalized for blowing up and having a total disaster. And the opioid addict basically maintained himself and worked on opioids. And so that's kind of been an underlying principle for opioid use disorder, which is if a person is dependent and we provide them with opioids, they actually can survive. And if survival is your outcome measure, if overdose, prevention of overdose is an outcome measure, then opioid replacement is certainly a good idea. So drugs stimulate their own taking. That's now the definition of any drug of abuse. And in another talk I give about the development of new treatments for eating disorders like obesity or binge eating disorder, those treatments, the FDA mandates that we test them for self-administration proclivity to just prove that they're not going to be self-administered and dangerous drugs of abuse. Before they approve them, they just make you screen in that way. So self-administration just simply means if you take a drug, just taking it makes it more likely you'll take it again. Makes it more likely you'll take it again. Makes it more likely you'll take it again. Now, you can throw in all kinds of caveats, like if you inject a drug, that would be the greatest risk, because you get the most brain concentration in the shortest period of time, the most dopamine released in the nucleus accumbens in the shortest period of time, and there'll be conditioning onto that. Everything conditioned to that drug event. So if you place Steppenwolf, activate the telegraph key, and then the animal does it, all you have to do eventually is place Steppenwolf, and dopamine is released in the nucleus accumbens. You can switch them to a placebo, dopamine is released in the nucleus accumbens. Your brain learns how to mimic every drug for a certain number of things. So self-administration isn't trivial, it's really important, and it says you should be deeply concerned about trying, because while somebody who's had trauma may have a very few uses that they can get away with compared to someone else, everyone could self-administer given the right dose, the right duration, the right route, without question. After self-administration is established, it can't be eliminated by punishment. So for the animal scientists here, you'll know that if an animal prefers one paw or uses the front paw in self-administration, what we do in the lab is we cut off their paw. And then they switch to the back lip, hind paws. And you just remove all the paws, and they hit the lever with their chin. Not unlike what happens in the human condition, where the fear or pain or punishment or stigma have no effect, maybe have an amplifying effect on drug taking. As you consume more and more, the risk becomes greater and greater because, as we showed in the dopamine papers for cocaine, you just use up the messengers that you need for the normal production of pleasure and reinforcement. They're just not there anymore. Our group showed that the cocaine dopamine hypothesis by showing the brain couldn't possibly manufacture dopamine as fast as cocaine could use it up. So you got anhedonia as a rule. In cocaine addiction, you get depression, not euphoria. In methadone maintenance, you get depression, not euphoria. The drug is just replacing what's missing without the pleasure. And that's also why people in drug treatment seek other forms of pleasure, to try to feel something. And it's very, very difficult. They have cue, and they all are triggers to consume, but normally it's just like cigarette smoking, where you feel a craving, it's a negative effect, and you seek and use the drug. What are the symptoms of OUD? They're in the DSM, and everybody knows what they are, but it's taking more than intended, which is the rule. Failed attempts to cut down, excessive time spent thinking about it, craving, work failure, repetitive conflicts, giving up important things. Somebody here told me they were from New Jersey, and I remember the Whitney Houston story where the family said the first thing they knew that she had a problem was when she quit the church choir with her family. They were, well, how reinforcing could the church choir be compared to intravenous drug use or smoking drugs? OUD is determined by a number of symptoms. You have mild, moderate, and severe, depending on the number of symptoms. And then we have the myth and reality, that the person might say, like I presented a case of a doctor in the earlier case, they said they're not addicted, they don't need treatment, that it's exaggerated. It's a terrible role to be in addiction psychiatry, where you almost feel like you have to be a spy, or you need so much ancillary information because everything you say they deny. And it's the opposite kind of history that you were used to as psychiatrists. My mentor, Herb Kleber, used to say, you let the patient tell their story, and you say, talk to the hand, but please pee in the cup. The cup doesn't lie. The person who's addicted has to lie, has to minimize, has to try to convince you, because you're in between them and their drug. That's their job. They don't mean anything by it. That's their job. But they might really believe that they might be able to stop, or that they could stop on their own, but it's all not quite true. The rationale for medications are based on outcome measures. NIDA's outcome measures would be overdose, retention, like showing up for next dose, not going to emergency room or having a crisis or a catastrophe. As compared to psychiatry, in addiction, we don't talk about return to premorbid function. We rarely talk about outcomes in the same way that we do in psychiatry. But it's very important because this is a lethal disease in days, weeks, and months. Relapse rates with just detoxification are very high, 90%. But the higher treatment retention in the medication-assisted treatment have less relapse. Maybe you could, if you looked at even manufacturers' labeling for buprenorphine, they'd probably put it at 50% or so dropouts in a 6-month to 1 year period of time. Overdose survivors who receive medications have better survival. That's just a fact. Now, the most recent data, which we'll get to quickly, says that even if that's true, very few people with an opioid use disorder who overdose take their medication-assisted treatment. There are a combination of reasons for that. One is the rescue tends to be done by people who are not providing the treatment, and so there's a handoff problem. And the second is they might not want to stop. You might want them to stop. And as I described before, it's hard to think like your patient in this case. The best example is the New Haven overdose epidemic, where 120 people overdosed in the course of 2 hours in the New Haven Green, and my mentee was the first responder and giving naloxone. They ran out of naloxone. And you go like, well, how did that happen? And he said, well, you don't understand the user. The first person overdosed, we rescued them. They text message all their friends to say they have the best drugs ever in the New Haven Green. And the friends come down. So this handoff has been a big problem. Treatments do work with the outcomes that we've defined. You just have to stick to them. So you reduce, if overdose is your outcome, medication-assisted treatments are an answer to that. If cure is an outcome, we don't have a cure. So we have to kind of come up with what's best for the person given their circumstances. But right now, most people do not initiate treatment. Of those people who do initiate treatment, most people drop out in 6 to 12 months. The probability of an opioid overdose is decreased by treatment. So just looking at opioid overdose, any of the medication approved by the FDA for opioid use disorder will decrease overdose and improve outcome, whether it's methadone, buprenorphine, buprenorphine plus naloxone, or naltrexone. They all work. Methadone. I worked in a methadone program at Yale and ran that program for many years for Herb Kleber, who's deceased and was a great guy and was my mentor, and we got him a Google page to memorialize him as a pioneer in addiction psychiatry. If you did a Google search on right after he died, he would have come up. You wouldn't know who he was, but for us, it meant a great deal. He was at Lexington, and we had, when I was running the program, about 300 people on methadone and about, 6 people on naltrexone. But one thing we learned at that time is if you had a choice paradigm where here is a nurse and she could give you methadone, and here is a nurse and they're right next to each other and she could give you a pill of naltrexone, everybody got in the methadone line because methadone stimulates its own taking. It's used for pain. It's an opioid agonist. Naltrexone does not do that. So you would have to take it because of a reason. And in our case, we had the first demonstration of that reason was you were a doctor. So naltrexone was approved first off as an oral pill. Chuck O'Brien and our group showed that if a medical board said you had to take it, you took it. And that was the only patient that would take it compared to methadone. But methadone's the gold standard. In 5-year outcomes, 80% of the people are still taking methadone. That's a lot of people and are not overdosing. That's a lot of people. There are problems with methadone as well. You need to have a licensed clinic. It couldn't be done in an office setting. Doctors treated with methadone don't like it, just like some patients in oncology don't like opioid agonists. It clouds their thinking. So some jobs might make it difficult to be on an agonist. And some of the programs have devolved into vending machines. So they have nothing else other than giving somebody a medicine. And that has turned out to be quite difficult because the patients then drink, have psychiatric problems and other problems. But nonetheless, you can see that treatment does work. Treatment works for buprenorphine, sublingual, subcutaneous. Treatment works comparing. All of the approved treatments have demonstrated efficacy. The challenge in naltrexone, of course, is the person has to be detoxed or they're not addicted in the first place. So the way that the XBOT trial at Columbia went was they took people who had detoxed, and they counted the passing a naloxone test as day one. And then they compared them to buprenorphine patients, and they each had day one in that way. And then if you compare them going forward, the outcomes are actually identical. So the challenge is, could this person be detoxed? Are they willing to be detoxed? Do they have the resources to be detoxed? Can you detox them in a safe enough environment that you could give them naltrexone and block their opioid receptors and prevent them from being able to overdose? And again, in this model, the most of the cases tend to be business executives, people from drug-free jobs like Secret Service, or people that are health professionals. And there's really no significant difference between the injectable once-a-month naltrexone and buprenorphine naloxone in outcome. If relapse rate is 50%, dropout rate is 50% for people with opioid use disorder given MATs, what is it for physician addicts? Well, physician addicts have coercion. Coercion works. In the state of Florida, we actually have involuntary hospitalization for addiction. So we can treat people quite aggressively. But if you look at 16 physicians' health programs around the United States, you'd see almost 80% are drug-free and back at work at 5 years. So whether you call it coercion or whether you call it incentives, this kind of form of treatment really does work, and it saves lives. In the state of Florida, the PHP program mandated that anesthesiologists with opioid use disorder who go back to work had to take injectable naltrexone. And in that sample, it was shown that not only did you reduce relapse, but you reduced deaths from the anesthesiologists who refused treatment. As we said, some doctors don't like these patients, and some doctors won't treat these patients. We need more providers. The providers list provided by our government is so bad that when you actually call the numbers that SAMHSA gives you for doctors who are willing to treat patients with MATs who have opioid use disorders, it turns out in this 2020 reference that few of them actually are real numbers. Some are disconnected. About half of them, you can't reach the providers. And the other, some of them had 120-day waiting periods. You can see that we have a shortage of doctors, and this is a breakdown on the data in the 2020 study, but you can see that some of the buprenorphine providers have unlisted numbers. It's really hard to find somebody with an unlisted number. Okay, so other differences between the MATs. This is the Penn Group's work that shows that naltrexone has a preferential effect on paraphernalia-related craving. So going back into your environment, that it would reduce the craving produced by seeing the same sights, sounds, and paraphernalia that were associated with your use. And that might be why it was so effective with anesthesiologists going back into the operating room, because they have that all the time. So we have a situation where we don't have enough providers. We do have 4 good treatments. We have lots and lots of patients who need treatment. And what's tending to happen now, and this is new WashU data from David Patterson, looking at local providers, is that we get comfortable with a certain provider and we'll send them the patients when they relapse, and it turns out that many times the person is given the same treatment, assuming that it would be better the second, third, fourth, fifth, sixth, seventh time. And they have 7-time attempt treatments in the same treatment paradigm. Okay. Treatment does not negate risk of overdose. So when you hear a patient say, why isn't that my loved one isn't cured yet? Or how come they still go to meetings? or how come they still take their medication? You need to know that the most current data suggests that a person with opioid use disorder is never cured and and we can't reduce their risk of overdose or significant emergency without them being treated. So while naloxone is a wonder drug and we have to be able to know how to use it, and we have reversed lots and lots of overdose deaths, and prescriptions have increased, when you look backward at the number of high-risk prescriptions for pain, we find only 1 in about 70 prescriptions did the doctor tell the person that they needed to carry naloxone with them. This is a mistake for people on benzos plus opioids for pain, for people on high doses of opioids. We had Dave Barron participate in this, and he talked about some USC athletes who broke their femur and how difficult it would be to counsel people about their risks. Naloxone dispensing is greatest in areas with the most doctors that know about OUD. It's not a cure. If you have to rescue somebody, keep in mind that you should call 911. You'll run out of naloxone, and the medication, the drug they've taken may last longer than the naloxone lasts. That's a very important thing to keep in mind. Opioid use disorder is a brain disease. My own work has showed that it's not pre-existing, it's caused by drugs. Some risk factors can increase the reinforcing capabilities of drugs. In addiction, we always say, never get too hungry. So obviously, drugs are more reinforcing when you're hungry. Drugs are more reinforcing when you have a significant comorbid psychiatric disease. Drugs are more reinforcing when you've had sexual, physical, emotional trauma. But after initial use and repeat use, self-administration kicks in, and then drugs change the brain. Can we change the brain back? That's the big question, but that has never been a target for addiction medicine or addiction psychiatry. It isn't regenerative medicine. It's more, we're focused on keeping the person alive. I'll go back to Nora Volkov's own work, looking at our cocaine addicts 8 months post-cocaine evaluation and treatment. D2 receptors are downregulated in at least 3/4 of the patients and persistently abnormal for the duration of Jean-Jacques Wang's study. We expect the same thing would occur. If somebody can figure out how much morphine equivalent endorphin do you have in the brain? 1 milligram? A half? You pick a number, but the average methadone dose is 100 milligrams a day. There's no way that the brain isn't reacting to that agonist by making compensatory changes that make it very difficult for the person to withdraw. That's good if an outcome measure is death, 80% retention. You have a lot of good things that come out of that. But the person is in quite a different situation than they would be if they were on naltrexone, and every month they could decide that they wanted to change what they were doing. You could go from opioid agonist to naltrexone, easily integrated in your practice. You can't use methadone, but you can use, of course, Suboxone and buprenorphine and naltrexone. Treatment failure and relapse may have less to do with the person than our understanding of the disease. We don't understand all the pathways. We don't have a personalized medicine approach. We only right now know how to keep people from overdose, keep them retained in treatment until we develop regenerative treatments, personalized medicine treatments, and it's more of an accommodation with where we are today. However, keep in mind that for opioids, we're in a lot better shape than we would be for cocaine or methamphetamine. What's the treatment for cocaine overdose? Pack them in ice. It's basically you prevent the hyperthermic changes. Same thing for methamphetamine, symptomatic body temperature reduction. There's no naloxone. What do you have for medication-assisted treatment? What do you have to treat them so they don't self-administer cocaine or methamphetamine? Nothing. So what's next behind the opioid crisis and epidemic is this emergence of a psychostimulant epidemic. Cocaine has gone from number 6 on the death list to number 2 in the last year's CDC death list. Half of the cocaine overdose deaths are due to fentanyl, which means, according to David Musto and Bob Bick and the drug historians, every opioid epidemic is followed by a psychostimulant epidemic because the middle piece is always a speedball piece, like a Saturday Night Live piece, and which is cocaine plus heroin. In this case, it's cocaine plus fentanyl. And that's morphing toward cocaine use or methamphetamine use, which we see. So we're in this phase of the I should remind you, I have a blog, and it's weekly. And then next week is going to be on opioid use disorder and how the most recent data shows that no matter when a person stops treatment or no matter what the psychiatrist or treatment program says, they're at perpetual risk for relapse. Declaring a person a treatment success does not prove that they're a treatment success. And in the most recent study, it's in the AJP, but there's 2 other studies very similar, looking at post-treatment and emergency room visits and overdoses. They occur continuously. The longer treatments, the better. As I said in the recovering anesthesiologist talk, we treat anesthesiologists for a minimum of 5 years with injectable naltrexone. Longer the better. In the studies of MAT, buprenorphine and buprenorphine naloxone, the studies show that at 6 months, when the person drops out, their relapse rate is pretty much the same as it was before. Their overdose rate was pretty much the same. The most benefit occurs at 1.5 to 2 years, but still there's a significant risk and a risk forever. And in those cases, again, we would say the person, their loved ones, their social network should carry naloxone, and that this kind of assumption that the disease went away without any regenerative treatment, without any treatment that was restorative to premorbid function, is more of what I showed in that slide, us joining the patients in a wish rather than in what we know from the evidence. And there's, last but not least, that OUD puts patient at risk for overdose. Ted Cicero and I are looking at where overdoses most likely occur and what are the best places to keep naloxone, and those places are not always obvious, and that's why this needs study. If it's a younger person, it tends to be in their house, in their bedroom, in their bathroom, in their basement. If it's a person who is living with friends, it tends to be in that environment or in a party environment. Having the person carry naloxone, I think you're the one that said that, or somebody did, is great if you have an arm bracelet that says, if I'm unconscious, naloxone is in my left pocket. Because if somebody has seen someone rescue themselves, please tell me. For the most part, they need another person to do this, and that other person needs to have access to naloxone. Okay, so I have a lot of good questions. Thank you. I would say, what's the correlation between the limitations in psychosocial treatment, support, and therapy and treatment resistance and outcome? So for physicians in treatment, we have a lot going for us. They'll come into treatment and they'll get a multidisciplinary evaluation. A neuropsychologist will evaluate them. There'll be fitness for duty testing. There'll be psychiatric evaluation. They'll have infectious diseases looked after. Their general medical condition will be well known. They'll get a history from their loved ones. They really have it. And then they meet with the physician, usually, and their chief of staff or their loved one, and they'll say, blank, 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 blank. For the regular person, they tend to get a treatment episode like this: overdose, rescue, referral to MAT, if that. The handoff is weak, as you see. Psychosocial treatment is the most important thing, and that's what separates addiction psychiatry from a vending machine. Without a patient engagement, the patient won't understand the importance of treatment. Can you imagine? Why would you take naltrexone injection once a month if you don't have a problem anymore? You need to be in treatment to know you have a problem. You certainly, if you're on 120 milligrams of methadone a day, you don't have that free will. But in the other treatment options, you do. And even in methadone, retention and methadone programs and outcomes are much, much better with psychosocial treatment. In Switzerland, in the heroin maintenance program experiment, the #1 cause of death is alcohol-related hepatitis and alcohol-related problems. Without concurrent treatment, they'll find another drug and another option. Any of your 1,000, thanks. This is, so there's a theoretical question that I'll deal with by saying we don't know the answer. But the assumption that I have in opioid use disorder and opioid use treatment is that clinicians assume that patients have acquired an opioid deficiency, and they're treating them on the basis of that. That when you looked at the Dole Nicewander original methadone program papers, they said like people developed an opioid use disorder, a disorder for which there was no real treatment anymore because they had broken the switch and they needed opioid replacement forever. Somebody asked me about kratom, and it is a over-the-counter opioid-like drug that has become a primary drug of abuse, has become an added drug of abuse, and there are plenty of reasons for concern, and as well as the use of naloxone in those situations. Does a patient, do you test or worry about marijuana? For physicians, we do. It's a drug-free job. For nurses, we do. It's a drug-free job. Work in Secret Service for President Obama, it's a drug-free job. Outcome is considered drug-free outcome. Why would that be? Because all drugs of abuse stimulate their own taking, cause dopamine release in the nucleus accumbens, and change the brain. So yes, it's a drug like other drugs, and yes, I am concerned about it. Do you think buprenorphine should be lifelong? Right now, the data is it definitely should be 2 years. That would be a goal that would be worth attaining, and I suspect that even after that, I would switch the person to Vivitrol. I'd be unlikely to think about having someone who's acquired opioid use disorder be treated without any of the MATs. I really like injectable naltrexone. As I said, I did one of the original clinical trials on naltrexone in the 70s. The injectable gives you once a month. The challenge, of course, is the outcome depends on patient adherence to the treatment protocol and is 100% voluntary. There's no unless you have coercion, you're in a situation where they have free will. And Nora has talked about this often. She said that maybe opioid use disorder is a disease of free will, and that creates a special challenge in treating people with opioid use disorder and should be kept in mind at all times. Thank you very much.